Good afternoon. I'm Robert Bush. I'm an Associate Editor of the Journal of Allergy and Clinical Immunology. This afternoon we're pleased to have with us Dr. Sally Wenzel, who's head of the Asthma Institute at the University of Pittsburgh Medical Center. She's here to discuss the upcoming paper that she has in the journal entitled The Efficacy and Safety of an Anti-IL-13 Monoclonal Antibody in Severe Asthma, a randomized trial. Dr. Wenzel, it's a pleasure to have you here this afternoon, and welcome. First of all, could you tell us a little background of your study and why you chose the study?
Well, certainly there's been a lot of interest in the role that type 2 cytokines play in asthma. That's been going on for 30 years now. And I think over the years we have come to the realization that type 2 cytokines may not play a role in every asthmatic. Maybe there are some groups that are identifiable by biomarkers. Maybe there are some groups that are identifiable by severity of disease, etc. But there's been a renewed interest in targeting this pathway. And certainly from the standpoint of patients with more severe disease, there's a real unmet need in very severe asthma.
I would agree with you on that. That's a very troubling area of treatment of patients, and trying to find new approaches is very appropriate. Could you tell us a little bit more about your study, the design, and methods?
Yeah, so this was a design targeting severe asthma. And I think what made this study unique is that among several of the other studies that are including patients with evidence for type 2 inflammation or more severe disease, that I think this study was absolutely the study that has been the study to date that has been done in the most severe asthma population. And it was done very carefully in identifying patients on medium to high dose inhaled corticosteroids. The vast majority were on high dose inhaled corticosteroids or oral corticosteroids, and actually 16% in this study were on oral corticosteroids, which is very different than any of the other anti-IL-4, IL-13 trials to date. So we recruited these patients, and then they all went through a 6-week run-in period. And again, that just differentiates this study from several of the others too, because all patients were put on high-dose fluticasone at that point, so 1,000 micrograms per day. And even after the 6-week run-in period, they had to have manifestations being uncontrolled. So their ACQ had to be greater than 1.5. And there was, I think, an initial check on adherence. So these were patients where adherence wasn't an issue anymore. They were being provided the medication and still remained poorly controlled.
So we're seeing a very severe population uncontrolled on conventional therapy, basically.
Correct.
So what were the results of your study?
Well, it's an interesting results, certainly. These were patients, I should also emphasize, that not only did they have a low ACQ, or high ACQ, I guess I should say, 2.6 was their average ACQ, highest of any of the studies that have been done to date. They also were very obstructed in their FEV1, in their pulmonary function testing, in the 55–58% range. All of the other studies have been done in patients with 70% predicted FEV1, so a more severe population from that standpoint as well. We took all comers into the trial, so there wasn't any phenotyping done up front. And in this very severe asthma population with average eosinophils in the peripheral blood of around 270 per cc, there was no effect of anti-IL-13 whatsoever, which I think took a lot of people by surprise, that it was so flat.
So this is surprising, this result, of course. And given that there have been other trials of IL-13 blockade, how do you reconcile that, or do you have any thoughts on that?
Well, clearly it's a million or probably billion-dollar question, as it were, for drug development issues. But certainly I think there are multiple potential reasons. I will go on to say that even though it wasn't pre-specified to look at eosinophilic patients versus non-eosinophilic patients, etc., those patients were looked at in this trial. And there really wasn't an incremental improvement. Maybe a little bit of a hint of more of a signal in patients that were more eosinophilic than others, but really not dramatic. So even when you pulled out patients who you felt had a type 2 signature, you really still didn't see anything. So from my perspective, I think the problem's potentially molecule-related, that just didn't have good binding. But they had preliminary studies in a milder population of patients which seemed to suggest that that was not the case. They had a reduction in exhaled nitric oxide in that early study in mild asthma that they did not replicate in this second study, but at least suggested that there was efficacy, biologic efficacy of the compound. There are certainly considerations of, in severe asthma, the molecule isn't getting into the tissue as well. Maybe there's more edema, there's more matrix deposition that somehow or other prevents the molecule from getting into the tissue as well. Maybe it's the fact that it's IL-13 only and not IL-4. Maybe in a more severe population you need to block both. The dupilumab approach was, of course, to block both through blocking the IL-4 receptor, and that study showed quite good results, but was done in a less severe population. And then I think the last possibility really is that severe asthma, this very severe version of severe asthma, is not quite as Th2 dominant a disease as perhaps even the moderate to severe asthma population. Like I said, when you're talking about FEV1s in a 55% prediction,
well, clearly this is a very severe population
yes, of patients. And we actually see in some of our data that there are other cytokine pathways that appear to be activated in this more severe asthma population. And perhaps you need to block more than IL-13 in this group to see efficacy. The other thing that concerns me a little bit is there was no impact on blood eosinophils or on IgE levels. So again, that actually suggests to me that there may have been some molecule problems as well.
Yes, I would agree with you. So the implications are we're still going to be looking at IL-13 blockade and perhaps additional cytokine blockade in various populations. And I know you have a very profound interest in trying to identify patients who are likely to respond to these treatments, and especially in severe asthma. Would you care to expand on that a bit?
Well, certainly. And I think moving forward, there's a tremendous amount of interest across the board in academics and in the industry of this new class of compounds. And at this time, no one really knows whether blocking both IL-4 and IL-13 or IL-13 alone or anti-IL-5 gives you the best results. So all these studies are going to teach us a tremendous amount. But I think there is also a great deal of interest in identifying these patients up front. So how can you suggest that this patient compared to that patient is going to be responding better to one drug or another? And those are areas we're very interested in. Blood eosinophils looks like it's going to be a pretty good biomarker for a type 2 inflammatory process. Blood eosinophils are about as cheap a laboratory test as you can get on a CBC, which is a really good news in these times of the rising costs of medicine. But there are also exhaled nitric oxide probably plays a role. Certainly we have reported that IL-13 induces the expression of the enzyme that makes exhaled nitric oxide, so that would seem to be a pretty good biomarker to use. And then, of course, periostin is the last one that's on the short list, I guess, of potential biomarkers, which also seems to be induced in epithelial cells in response to IL-13 and probably IL-4 as well, which you can measure in the blood and in serum, and seems to give you some indication of the type 2 cytokine activity in the patients.
Well, I look forward to more studies from your group, and I appreciate your time today. Thank you very much for being.
Thank you very much, Dr. Bush.